3, 2, 1.
Good morning. I'll call the Kennewick County Health and Human Services Committee to order. The first order of business this morning is to approve the minutes. You received them in your Dropbox. Entertain a motion to,
I will make that motion.
Raleigh moves to approve the minutes. Do I hear a second?
I'll second it.
Dwayne, Commissioner Anderson seconds. Any discussion? Hearing none, all in favor signify by saying aye.
Aye.
Opposed, same sign. Motion carries. We also have the bills to pay.
I so move.
Mr. Berg moves on the bills. Mr. Gardner seconds. Any comments or questions? Hearing none, all in favor signify by saying aye.
Aye.
Opposed, same sign. Motion carries. There is one warrant to cancel. I'd entertain a motion for the cancellation of that warrant.
So move.
Mr. Gardner moves. Do I hear a second?
I'll second it.
Raleigh, Mr. Nissen seconds. Any discussion? All in favor signify by saying aye.
Aye.
Opposed, same sign. Motion carries. All right, then down to the good stuff. Tamara, you're going to speak to us about home and community-based services. Good morning.
Good morning. I think I will take my mask off
Please
if that's
do.
okay, because my glasses will probably fog up otherwise. So good morning. I am here to talk to you about the Home and Community-Based Assessment Unit in regards to how 2020 went for us. So kind of to start with, 2020 was a year of many changes, not only COVID-19 for us, but we had some additional changes that I'd also like to talk to you about today so that you can kind of have an understanding of how the year went for me and my personnel. I started out the year with one unit, the Home and Community-Based Services Unit, or the MnChoices team. And then in the fall, I also started to supervise the Blue Cross Blue Shield Care Coordination Community team as well. So currently I have 2 teams of staff that I supervise. I have 10 MnChoices assessors, 3 case aides, and 5 care coordinators. So I have a total of 18 personnel that I'm currently supervising. The teams are very distinct from each other, kind of giving a background for some of you that are new as well. The MnChoices team is a group of individuals who operate under programs administered by the Department of Human Services. So they provide us policies, procedures, and computer systems. The Blue Cross Blue Shield team is a group of individuals under contract to Blue Cross Blue Shield. So Blue Cross Blue Shield administers those programs, provides us the delegation guidelines, policies, procedures, and their distinct computer systems. There is some crossover, for example, with MMIS2. So that kind of gives you a little background of the group of individuals that I'm currently supervising. In 2020, we not only had to deal with the COVID challenges, but we had a 40% turnover in the personnel in our MnChoices team. 2 for retirement and 2 resignations. And we had 2 of our support staff that went out on extended medical leaves. So we dealt with those, got new individuals hired, but that would be part of my presentation a little later explaining how that impacted us. The Blue Cross Blue Shield Care Coordination team, since I started supervising them in fall, had a turnover of 1 FTE and had 1 individual that was on an extended maternity leave. So there was also staffing challenges as well. That kind of brings me into part of what I wanted to talk about today was with COVID-19 and all the significant staffing changes, how were we able to successfully navigate the year? And I believe strongly that was because you allowed us to do remote work. So wanting to extend a thank you for doing that and kind of explaining to you why that worked so well for us. With this team I have, those individuals, everyone except for 1 FTE worked almost 100% remote since March of 2020. The reason the 1 position stayed in-house was that prior to COVID, her job responsibilities were the same during COVID, but to do them, she had to have access to equipment and network systems that you have internally that aren't available readily external. So she was doing our mailing, our copying, our printing, and doing imaging into Caseworks, which with large volume documents, really requires the internet service we have available here in the building. So other than that, everyone else was remote. To kind of give you a background, why was remote so successful for our team? Corky knows about in 2014 or so, we made the decision we wanted to move all of our processes to electronic version from paper. And about 2016, we were totally successful with that. So we were pretty much almost completely paperless prior to COVID, and we only would send out the documents at the end of the process to the recipients. Everything else we did electronic. Our staff had laptops, bar scanners, signature pads that they went with out into the community when they did their work. So that was key. Because my staff pretty much has everything at the fingertips in their computer, they didn't need file cabinets, things on their desks to work. And so that allowed us pretty much very easily to convert them into remote methodology because everything went with them when they left. So with that in mind, the other thing that happened was the states and the feds allowed us to do remote assessments, pretty much phone assessments. So we were no longer seeing people in person, we were seeing them by phone. And again, we have what we call our smartphone technology. They were able to basically use the cell phones, which are required for the MnChoice's assessors to a statute requirement, or the smartphone technology for the care coordinator to do all of the phone calling directly from basically out of their computer or through the agency cell phones. I'll talk a little bit more about phone assessments a little later when we talk a little bit more in depth about MnChoices. So with those things, our staff still, even though they were remote, had numerous COVID exposures that happened throughout the year just because of their personal lives, their families, their children. And that in turn did result in those individuals, if they had been in office who had had extensive quarantine periods of time, they were able to continue to keep working. And I believe that was really key for us to be able to handle the volume of work that we have before us to work with. And remember, we had a 40% turnover in personnel. That slows you down no matter what you do. Because of that, staff really were able to become very productive, and we did not miss any major deadlines or timelines. Everybody's assessment was done on time, and in addition, we were able to ensure providers got paid. One of the key things that we'll talk a little bit about MnChoices is that it's a very time-sensitive program. You have a specific window that you have to complete the assessment in, and if it is not done, everything stops for the clients. Their services stop, the providers stop getting paid, and there's no retro eligibility. So for our area, there's no ability to kick the can down the road and say, we don't have enough staff, we can't do it, we'll do it later. It doesn't work. It has to be done, and it has to be done prior to keep the services in place and to keep our very important providers in our community paid. So with that, we want, again, as I said, remote work really helped us be able to maintain that with all the changes that we had. So one of the questions was how did my staff relay information back and forth as well? So one of the things I required them to do was an AM check-in. They would basically give me their to-do list every day. They would also tell me, do you need to call me? I have questions on the following. Do you know anyone that worked on this item? And I was really able to organize my day to facilitate communication of information back and forth. As well, in the afternoons, they would do a PM check-in as well, where they basically told me what they achieved. It really gave me a good handle, probably a better handle than I had when I was in the office, knowing what they were achieving each and every day. The other thing that they did is, and Corky knows this is a big achievement, they did their SSIS time reporting daily, completed 100%, which is amazing, which also helped with our revenue as well, particularly for the care coordinators. So that was a nice achievement as well, and then basically they would report what they did for 7 hours a day and file those with us. The other thing that I learned through remote was how to use electronic systems that we have available, but how to use them as a supervisor to really know what my staff are doing. You know, when you're in the office in your close proximity, you're walking by, yep, they're working, but what are they working on? I learned how to use Caseworks better so that I could actually see in real time what documents were being put into filing, by whom, and how long it was taking them. We had our H drive. I was able to monitor what was coming in for mailing, when it was pulled out for mailing, what was dumped in filing, and when it was coming out. So with that, I learned to use a lot of those systems to better monitor my personnel and staff. So in the end, in the summary, we have been using electronic tools, but we've all become better at it. And I would say my staff would tell you that as well. One of the things that we learned that we're going to keep is we would always bring our mail in. Someone would open an envelope, put it in a mailbox, then everybody would paper process it. Corky remembers the blue folders. You put them in alphabetical, someone around comes and picks them up, and then we would put them electronic. What we did during COVID is we scanned them in right away. Everybody loves it. They can handle their information immediately. They can delete it, they can put it in for review, or they can immediately dump into filing, or if it's a big document, they dump it into imaging for the person internally. And that's something they're all in agreement we want to keep into the future. So in that end, I believe that, again, your willingness to let us do remote was key to 2020's success for my team. And I think my team would express that as well, their appreciation, because we were able to do it quite efficiently, actually. So appreciate that. To kind of talk a little bit more specifically about HCBS assessment, today I wanted to talk a little bit about MnChoices in 2020 and how did that particular area go. Unless someone has questions.
Mr. Chair?
Yes, go ahead.
Yeah, I'd like to ask you a couple of questions and a comment, too. Things have really changed in the last decade or so, especially with all electronics, but knowing you, I have no doubt that you got things well organized. One question I had, the things you've learned now and all the training you had to do had to be unbelievable to get everybody up to speed, because you can only be as good as the slowest person, probably. The things you've learned now, working remotely, and people be coming back in, can you still learn some of that information and still use that additional? Does that make sense?
Yes, and I think myself as a supervisor, I really now know how better to use electronic systems to monitor what's going on daily. So I will continue definitely doing that. I think as we come into the office, I've just told my staff we have to decide what we want to keep and what we don't want to keep. For sure, we want to keep the scanned mail. The AM and PM check-ins, we may or may not. I will ask them how they feel about that. But also, the SSIS time reporting is something that I'm going to ask them to keep doing for the next 6 months, just because to help shore up our revenue, particularly in the Blue Cross Blue Shield care coordination area. So I've provided them that information. If for some reason it's harder for them to be able to do that internally because of reasons that their productivity isn't as good or whatever, we'll have to alter that, but that's one of our goals. So we've talked about that as a team already.
Okay. Some of the waivers, Mr. Chair?
Go ahead.
Some of the waivers that we got, or the county got, and you got, can you still continue those to a degree, and will that still help out?
Right.
moving on?
So with MnChoices, we have permission through June 30th by the governor's executive order to continue to do them by phone. The federal government is discussing very seriously to extend the public health emergency through the end of 2021. What that means for us, time will tell. There was some legislation talking about continuing phone assessments into the future. I don't believe that got in the final bill as written. But we will be returning to in-person, and we will have to think through some of those challenges as well as we go forward. So I would tell you for sure for June 30th, and then I could come back and tell you more once I learn how the future will go. But that's the phone piece.
Okay, thank you, Tammy.
Yeah.
Anybody else have any questions at this point? Commissioner Nissen?
Yeah, I don't, maybe this is premature, but I'm reading your handout, and we're doing assessments for 69 counties?
Yep.
Explain why we're doing all those people's work for them.
Okay, well, good. So that kind of leads me into my next part of the presentation. So I'll just start that, and then I'll answer your questions. So for kind of a background for MnChoices, for those of you who are new and haven't been through one of my presentations before, Jenny asked me just to give you a little bit of background. Prior to MnChoices, there were 3 separate paper tools or assessments that were done for people to access the services or the same services MnChoices does. They were called a long-term care consultation, a personal care attendant assessment, and a DD screening. And you had to go through 3 different doors. If you went in this one, you weren't eligible, then you had to go in this one, and you had to go back and forth. DHS, around 2015, launched MinChoices, which was an electronic assessment tool that took all of those assessments into one tool and determines eligibility for 12 different programs. So you can see the breadth of the knowledge that my personnel have to do this program, because they have to know the eligibility criteria for all those programs when they complete one assessment. MinChoices is an electronic assessment and care planning system. So they are all electronic, there's no paper, everything you do is through your laptop when you're out there with your consumer. And it determines eligibility for all those programs. In addition, one of the other unique things about MinChoices is that MinChoices is a program that we don't travel out of county, but we're required to do assessments for any person who is here at the time they request assessment, no matter what county they come from. So right now, 67% or 58 of the 87 counties, and hopefully the report's correct, I'll have to, if I miss that, we do assessments for. So we are the second county that had the most significant impact by DHS changing the legislation to require the county where the person's at to do the assessment. Only Blue Earth had a larger change. And that's because we're such a significant outstate regional center. So we do, as I said, assessments for 58 different counties. The 5 top counties that we do assessments for is Chippewa, Renville, Swift, Hennepin, and Meeker. And we do assessments at MSHS, CARES, and CABS, and that's where a lot of the Hennepin County referrals or assessments are completed. So if that kind of helps you, it's mandated by statute that we do it.
Does the funding for the programs you place them in go back to the counties that they were from, or how does that all work?
We are reimbursed for MinChoices on something called a social service time study. So the revenue comes directly to us, but it isn't paid by assessment or by 15 minutes, how long it takes to do assessment. It is paid by a code selection that your staff selects based upon a random sampling throughout their workday. So again, remote work, really critical. We were able to continue to select those codes again through 2020. If they would have been out, we would have not had that code selection. So the more staff you have selecting those codes, the more codes you receive, the more revenue comes in. So preventing staff turnover, keeping staff working is really critical to how we get paid for MinChoices. So your direct correlation to the number of assessments isn't there, other than if your staff are doing that work and that code sampling is selected. So that's how we're paid for MinChoices. That's how the Department of Human Services made that decision. We made the decision to become a single county pool, an individual county for SSTS, because of the volume of assessments that we do, because we're so different than the counties around us. So that has helped. And Carol can talk a lot more in depth about that. But our SSTS revenue did experience a little challenges in 2020, some of it because of changes that DHS made regarding code selection, but also because we had turnover in staff. So whenever you have a staff that's not there to select codes, or if you have during training time. So keeping staff stability is important to our revenue in our area as well. So if anybody has any more questions about that.
One real quick question, Tamara, is, so I suppose the reverse is true. Also, if a Kennewi County resident was, say, up in Stearns County, then Stearns would be doing
Yes.
that assessment.
Correct. So in 2020, we completed 977 assessments, down slightly from 2019 by 12. Most of that was because DHS made some additional COVID changes, which stated there were some circumstances where the waiver would not have to be shut down. And that in turn then prevented a follow-up MinChoices. So small reduction, almost the same amount of work, just the difference in 12. So again, very successful that we were able to pull that off in 2020 with all the changes we had. We have 2 types of assessments. We do what we call initials. That's for a person who's not receiving any services or has never received services. Those assessments, we do about 15 per month on an average. They take significantly more time than the other type because we're doing the eligibility for medical assistance, making sure the person's certified for disability, and they take about an average of 15. We've had them go as high as 30 hours of staff time to complete. The other type of assessment we complete is a reassessment. That's for an individual, that's the bulk of what we do, is someone who's currently on programs. And what we're doing is we're ensuring and continuing their eligibility into the next year, renewing all the authorization so that their services continue and providers continue to get paid by putting in that they continue to be eligible. They take about 11 hours on the average to do. And we do those also for any county that has someone in Candy, Ojai County. Again. The one thing I wanted to say is phone assessments actually are taking us about 1.5 hours longer. We track the time for every assessment that we do, and we log it on a database. So we were able to split our database at the time we started with phone assessments. And I believe because we were electronic prior and we secured all the signatures at the assessment, we didn't have to mail out all the documents for signing and then have them returned. And then we have to send out the documents at the end like we did. But we have seen more time. So phone assessments for us have it and save time. If you were a county that maybe was 100% paper still with the follow-up besides the assessment, you probably aren't seeing any different. But for us, we did. So phone assessments are not a time saver for us. In fact, it also increased our costs in terms of mailing, copying, paper, toner, and postage that we haven't had before. So from our standpoint, we're fine with face-to-face assessments coming back because they seem to be more efficient for us from the procedural process pieces. Also, we would enjoy having the opportunity to go back and meet people again in person. So I also, during COVID, I think our intake personnel did an unbelievable job of facilitating all of these assessments timely. In addition, they were also able to tell me sometimes they would call people and they would say, I'm not feeling well. They were able to say, you know, if you're not feeling well, would you like information on how you could be tested for COVID? So they provided that to those individuals. Most people were extremely relieved that we were not coming in their home. Matter of fact, they would express, I'm so happy you don't have to do this in person right now. The final thing that we did during COVID was for PCA assessments. There isn't a care coordinator or case manager in the county for those unless they're open to another waiver or on Blue Cross Blue Shield. So we have many individuals that facilitate their own provision of care. And what we did is we would actually reach out, which we aren't required to the PCA agency if we hadn't received the referral during COVID, to say, hey, we're concerned. We know you are missing some referrals for Candy, Ojai. Can you double check? Because we didn't want people to have an interruption in their PCA services during COVID-19. Towards the end now, we've gone to actually sending out notices to them, to the client and to the provider, and we will take a referral directly from a client if they want to, trying again to make sure there's no interruption in their services. We talked a little bit about revenue and time studies, so I think I can kind of skip over that piece. If you have any more additional questions, I can talk about that as well. I'd like to end by, before I open to questions, is talk about 2021 and the challenges that my team will have in front of them. We are going to have Min Choices revised or revision launched. That's somewhat scary, but DHS promises us it'll be effective, efficient, highly usable tool. So we are going to get a whole new assessment tool in November of 2021, and our staff will have to get up to speed and trained on this new assessment. In addition to that, the Blue Cross Blue Shield care coordinators will have to do Min Choices assessments and not the legacy tools. So they're going to have to all become certified and be able to do Min Choices by the end of the year. The final thing that DHS is doing, because they never do anything small, they are changing the personal care attendant program into something called Community First Supports and Services. We're already getting people calling about this program for referrals. It doesn't change until after the Min Choices launch, which is at the very end of 2021, but it replaces the PCA program. It is virtually kind of the same program, but just called differently, but it offers two avenues. People can go through a traditional employer to get their PCA, like any PCA agency, or they can do what's called the budget model, and they would be given a sum of money. They would hire a coordinator to help them write a plan. Then under DHS guidelines, they could determine how that money was expended within the parameters of that program. Kind of similar to the consumer-directed community support programs that we have under the waivers. So we have a lot to learn because it's new to us. So we'll be learning how we will be involved. Any questions?
We'll take a couple quick questions, and then we're going to have to move on to the next presenter so we can get in on our time.
Sure. Impact would that have
Well, it would be,
on your program?
that's a really good question, but Blue Cross Blue Shield care coordinators then would become Prime West care coordinators, for sure. So primarily for the group that I supervise, they're for elderly over 65 population. I assume with,
Yeah. Okay, thank you.
yep.
Trying times to hold everything together back in, or at some point, some hybrid.
That we're willing to get out there and keep producing every day.
All right, next up. What you do?
Good morning.
Welcome,
Good
Denise.
Morning.
Take my mask off too so I can speak more clearly. For those of you who are new that don't know me, I'm Denise Kragenbring. I'm one of the supervisors in public health. And one of the programs that I supervise is emergency preparedness. So before Jenny does her updates, I'm going to briefly go over my annual report of what happened in emergency preparedness for 2020. As you can well imagine, there was a few things going on. Before I do that, I want to introduce a few people that came with today. I brought Shannon Templer with today. She's a brand new public health nurse that we've just hired, so give her an idea of what goes on up here and experience a board meeting. Jody Ammerman, you probably all know, she's the other supervisor at public health. And then Karen Ampey, she is our emergency preparedness coordinator for public health, so a big part of what's gone on in all of 2020 and continuing in 2021. So the rest of you have heard me every year come up and talk about emergency preparedness and all the planning that we do. We've been planning and planning and planning for years and many, many hours. None more than Karen. This is her gig. This is what she's been doing for years and years, writing plan after plan, looking things over, making sure everything is set. And you know what? We were ready. We were ready in 2020 for this pandemic, and a lot of that is due to Karen. So kudos to Karen. We're really fortunate to have someone like her working in that position. She's extremely dedicated. She's very detail-oriented. She's very knowledgeable. She's very driven, and I just want to make sure that we all recognize that, because that's a big reason why we were as prepared as we were. So you should all have the annual report in your Dropbox. Oh, I have a few extras. You guys don't have one. You have one, yes, there. So you'll have that to look through, so I just want to highlight a few of the things on here. I'm not going to read through the entire thing. But you can see January 21st is when the first case was in the United States. And on the January 30th, President Trump declared a nationwide state of emergency. So you can see it was a very short period of time, February 6th, when we first had a call together with our health and medical group. So those of you that don't know what that is, in our county, this is a long-standing group of health and medical people in our county that all work together. We try to message our community together. We try to move forward on things like this, unified together. So it is all of the medical groups in our county, which is primarily CARAS now, and our law enforcement, our emergency management in the county, our public health leadership. All of those folks get together, and so it was very early on that we did. And you can see there was very few cases at that time. There was 11 total cases in the whole country when we first started talking about, what might this be and how might we be responding. So by March 1st, the first presumptive case was in Minnesota. It was in Ramsey County. By March 13th, again, I'm just highlighting a few of these dates down here. We first sent out some communication to county employees. I believe that came from Larry, but just to try to let all of the county employees know what's going on. What is coronavirus? What does this mean? What are the symptoms? That sort of thing. And on March 16th, we opened up our incident command structure in public health. Again, these are all kind of some Greek terms, maybe to people that don't work in this every day. But for us, to use this incident command system helps us pull everything together and move through all the things that we need to do from planning to implementation in a very organized manner. March 19th is when the buildings in our county were closed. On March 21st, we had our first death in Minnesota. On March 26th, that's when we had our first case in our county. On March 30th, and Tammy was referring to some of the remote work that we've done over the past year, that was the first day that we started having staff in our county work remotely. On April 9th, Public Health launched our Facebook page, and that made a really big difference for us over the past year on how we can communicate with the community and how we can get information out there. So that was a wonderful thing. And big thanks to Mary Lopatka sitting back there. She has done great work on that. She's really the force behind our postings on Facebook. So thanks to Mary. Then I'm going to skip down to April 28th. That's when we had our first death in Candy, Ohio County. June 3rd is when our emergency preparedness coordinator, Karen, when she started working with emergency management, so that's Kim Lindahl and ACE for the county, when she first started working with them, looking at, okay, when and if this vaccine rolls out, what is it going to look like? How are we going to do this? And very early on, we started planning for drive-through clinics. We talked a lot about it and felt like that might be a really effective way for us to get some vaccine out there. And some of you may remember, we tested that early on in late 2019. We did a drive-through flu clinic for some of our employees just to see, how does this work? How can we do this? And it went really well. Staff liked it. The staff that went through to get their flu vaccine that day really liked it. So we just built on that. So we really started early looking at that, as you can see. That was in June. On July 23rd is when the governor put the mask mandate in Minnesota. So the next thing, you'll see a couple of graphs on here, and I just wanted to throw them in there as a little picture for you to just to kind of see how things moved through the months. That first graph, I understand it's really busy, and when you get a chance to look more closely at it, it'll make more sense to you. So there's multiple different things going on. The dark blue top line is the Minnesota cases, and the lower green line on the top half is Candy, Ohio's cases. Of course, you have to look at both sides of that graph because the numbers are different. Those are two different graph lines. But you can kind of see that we as a county moved up and down very similar to the cases across the state. And then the bottom half of the graph gives you an idea of what the hospitalizations looked like as we were moving through the different phases from staying at home to starting to move around a bit. There's multiple different things in there that you can look at that shows you kind of how the cases moved along for us, and different things that we added into our incident command structure. All through this, what I want to certainly point out is that we were always collaborating with other people. First and foremost with our health and medical group, certainly with our emergency management, and with Caris Health. Leadership in public health was involved in Caris Health's incident command system. We did attend some of their meetings, but we were always in communication with them through our health and medical meetings. So we were all through this doing very unified messaging and command on that. I may have jumped past that. March 26th, when that first no, that's not the one. The coronavirus corner, March 13th. So on the front, you'll see those couple of pictures of the coronavirus corner. That was a collaboration as well from emergency management, public health, and Caris Health to try to pull together messaging. And so we put that together. Early on, it was about once a week. Eventually, it moved to once every 2 weeks. And we sent that out to all county employees. Larry would send that out. We put it on our Facebook page. Emergency management sent it out to a number of our community groups. So it was just another way for us to get information out about what does this look like in our county, where might you access the resources, who should you call, those sort of things. And that was a very successful thing for us. Looking back again then on the back page, the other things I wanted to highlight is on December 23rd is when we here in public health first got vaccine. Vaccine arrived on December 23rd. So when you look at that from the big picture of start to end, it's pretty amazing. And so we were able to we did one vaccine event in 2020, and that was on December 28th. There's a little picture of one of our first drive-through clinics. Again, we've learned a lot since then, and I know Jenny's going to talk about things that have happened since the end of 2020, since this report is just looking at 2020. So you can look in that little box there about the year-end data. Will give you an idea of where we were as a county, where the state was in terms of our total cases, our active cases, our deaths. And then the bottom graph shows you the picture from start to end of the pandemic in 2020, what it looked like on March 18th, which is at the very beginning there, to what it looked like at the end of the year. Again, Candy-Ojai in Minnesota really kind of followed the same. You can see we're both on the same trajectory. I get it, the numbers are substantially different, as you can see, but if you can put the graph together as we did here, you can see we kind of ebb and flow very similarly. So the last thing that I want to point out is back on the first page, the hours of public health staff. So in all of 2020, we spent 7,921 hours preparing and planning and collaborating and communicating with all of our partners. I think I jumped over a few of the other things, but one of the other big things that we did as public health staff is we collaborated with Caris Health in that we were able to get notifications of positive cases, new positive cases in our county, and then our public health nurses called those people. We weren't doing the true case contact tracing that was being done by the Minnesota Department of Health, but we were that local person that calls you up and says, how are you doing? What can I do for you? Can I answer your questions? Can I help you with anything? We had very, very positive feedback from people. They were very appreciative, and it was a great local connection and a way for us to get information locally to people about what are the resources right here, what can we do for you, or how can we connect you with your needs. So looking at that, 7,921 hours is a lot. We spent a lot of time, but I think we were very successful in all of what we did. And again, I want to go back to, we were really well prepared for this. Again, big thanks to Karen, big thanks to all those years of planning, of poring over these plans and figuring out what does this look like, so that when something like this happened, we were ready. We were ready to do it. So the last thing I just want to emphasize again is that through all of this, it was a huge collaboration with all of our staff, with our medical partners, with our community partners. We had, as you'll look in there, we had liaisons that were working with communities of color. We had a Somali liaison, we had a Latino liaison, we had a liaison working with corrections, we had a liaison working with our area schools, we had a liaison working with Institute of Higher Learning, which in our county is Bridgewater. So lots of collaboration, and we should be very, very happy and proud that our county works in the way that it does, that many of these collaborations were in place ahead of time, and it wasn't a stretch to work in that manner, because we've been doing it for years and years and years. So that's what I have today. If there are any questions, I'm happy to answer. Otherwise, I'll give it over to Jenny.
Well, certainly, Mr. Berg,
Oh, why don't you go ahead?
I was just going to
You might be
say,
saying the same thing I might say.
you know, who knew all these years of planning and writing plans that you probably felt at times you're wasting your time because we're never going to, but who knew that all this planning would come together and we'd be facing what we did in the year. And there was there was frustration out in the public from people who say, well, they didn't do this, they didn't do that, or but it's pretty remarkable when you look at that time frame from where we're sitting right now to where we are in terms of now we're worried about using up the vaccines that we have and making sure people will come in and get those vaccines and get over the hesitancy or the politics or whatever is keeping them from getting the vaccine. So congratulations to everybody from Larry on down to, the people in the administering the shots. I have heard many, many times how smoothly it's gone for people who are getting their shots, driving through either place that they went to. So congratulations to everybody. We got a little ways to go here yet, but you've sure done a good job so far.
Thank you.
As an emergency preparedness coordinator, it wasn't a case of if this was going to happen. It was a case of when it was going to happen. And so.
You want to go to the podium, Karen, and identify yourself?
Okay. Karen Ampe, the Emergency Preparedness Coordinator. So in planning, in emergency preparedness, it was not a case of if a pandemic was going to happen, it was a case of when it was going to happen. So having the plans updated, kept current, was always very important. And I've been very fortunate to have support from my administration, from all you, and in the past, you can write plans, but how do you know if they're operational? So we've had a couple events in the past, a couple more like the active tuberculosis, where I had specifically requested that we open our Department Operations Center, our doc, and practice with new plans, new forms that we had done to make sure they were operational. And at that time, we practiced with our continuity of operation plan that I had redone, and the incident action plan, and the situational status report. And we tweaked them at that time. And we made several changes to things that we thought would work. And we fine-tuned them, and I'm detail-oriented. Denise is the epitome of detail. So between the two of us, we work real well together. So by the time we got into the COVID, we had these tested. And that's the big piece to emergency preparedness is pre-planning. Pre-planning with your partners, with the collaboration, and pre-planning. That is not when you want to get into a situation like this and then find out that you don't have current or workable tools, whether they be your job action sheets. We worked on 18 months on job action sheets, getting them to where we wanted them, and right now I'm updating them, tweaking them. So that's just what I want to say. It wasn't a matter of if, it was a matter of when. So, and then moving forward, when we close down our Department Operations Center, it will be updating everything that we've learned and new processes and best practices and updating our plans for the next one. And
I'm sure for someone like you, it was always a question of not if, but when. But for the general public who sees all that money and all that time being spent on things that they figure will never happen, to them, it's probably even a waste of money, time and money. So again, thank you for that. We better move on and let Jenny give us her update. Thank you. Sorry, Commissioner Berg, I didn't.
Fine. Pretty much the same thing I was going to ask.
All right, good morning.
Good morning.
Morning.
So we are, like Denise had mentioned, we have approached a year since we learned about COVID-19. So back on March 11th of 2020, COVID-19 was declared a worldwide pandemic. Our Candiota County Public Health Incident Command team began working on the responses well before the pandemic was declared. Our staff had to quickly adjust and shift from their normal lines of work to new duties, which we have prepared for in the routine emergency preparedness trainings often held and led by Karen Ampe. Our staff have rallied behind the new territories we were responding to with the state and national emergencies. Our staff provided education and resources to our community. We grew new and stronger relationships and partnerships with community businesses and residents. We were able to keep our county up to date with messaging around where our county stood with the COVID-19 pandemic. Our staff has been busy this past year and really have shown great resiliency through their work and the response to this one-of-a-kind pandemic. Public health has never been one to be in the spotlight, but this past year, our efforts and work have been highlighted all over. I would now like to share a slideshow that was put together to showcase and reflect on what this last year has been like for our staff here at Candiota County Public Health. So I thoroughly want to extend my thanks and appreciation for the outstanding work of this team here at Kandiyohi County Public Health. From the 2 supervisors, Denise and Jody, Kieran Ampey, our emergency preparedness coordinator, to each staff member, including the nurses that we pulled to assist in this response from Human Services. There really is no way we could have gotten through this past year without each and every one of them. I'm very proud of how they have stepped up and did what they have been asked to do. So I just want to say thank you for myself. Really quick, where we're at right now with the COVID-19 pandemic and vaccination efforts for our county. We're continuing to hold vaccination clinics through public health. Usually these have been weekly, sometimes a couple days a week, but we really have started to see things slow down. So gearing up for additional messaging. I know we just met with Caris Health on Monday, and they're doing the same thing to try to, again, eliminate vaccine hesitancy and go through, again, myths versus facts and really get our public educated. Right now, currently, as of yesterday's data, our county, we have had 15,182 individuals who have received their first dose of vaccine. This is 45.5% of our county's population. And then we've had 12,077 individuals who have completed their entire series. So that's 36% of our county's population. We are right now trending a little bit lower than the state. So just in percentage-wise, the state with first dose vaccinations are at 52% of our state's population, and then 36.9% have received the completed series. We really are starting to see some increasing inactive cases of COVID-19. Currently, we have about 127 active cases right now. So again, this means that individuals have tested positive and they're within their quarantine period. So I just want to remind everybody that we still need to be following the CDC and MDH recommendations that have been given. I think there's some feelings from people that once they get their first dose of vaccine, they're good to go, and yet you really need both doses, and then you need to be 2 weeks after that second dose to be considered fully vaccinated. So just if we can spread the word to assure that people are still following the guidance. And then if anybody else is looking for the COVID-19 vaccine, it's here, it's in our county. We have some available. So individuals can still sign up through the MDH Vaccine Connector. Check our Kandiyohi County website or Facebook page for upcoming clinics that we will have. And then also they can check with Caris Health. They're holding clinics usually Wednesdays, Thursdays, and Fridays. Or check with a local pharmacy because I know they still have vaccine. So other than that, I think we're running out of time unless someone has quick questions.
I think we better end it with that. I just want to say thank you guys for all the hard work that you've been doing. And with that, we will adjourn the